Welcome to the Transforming Healthcare Coaching Podcast, where we're all about helping healthcare professionals like you create positive change at work, at home, and everywhere in between. Hi, everyone. Welcome to the Transforming Healthcare Coaching Podcast. And this week, we are joined by a lawyer. Now, I know that can actually make a lot of people nervous. And I'm going to tell you, the lawyer that we have on today, Sarah Benator, is someone who supports us in the medical staff in our hospitals. And so I'm going to let Sarah introduce herself, and then we'll get into it.
Well, thank you very much. Hi, I'm Sarah Benator. I was a lawyer. I've actually left practicing law and I'm currently a coach, but I practiced law for 25 years and I worked with hospitals and with other healthcare entities. And most closely, I worked with the medical staffs, the organizations within the hospitals that oversaw the quality of care for the patient community there. So I got to work a lot with medical staff leaders like chiefs of staff, department chairs, credential committees chairs, in helping them achieve their goals of patient protection and quality care.
Awesome. We decided to bring you on primarily because I think this is a very unique position that you were in that we really don't often get to talk to and get to pick the brains of for what exactly does the legal counsel and the support and the process of just how the medical staff affairs even works. And you have advised dozens of medical staff leaders in your 25 years practicing. What are some things that you think would help new leaders be able to hit the ground running when they assume their leadership role?
So one of the first things I would encourage medical staff leaders to do when they're coming into a leadership position, and whether it's a medical staff leader or a medical director of a group, whatever you're doing as a leader, if it's different than what you did before, as physicians, you're leading in patient care, but you haven't necessarily had the experience of leading your peers in a mission-oriented organization whose goals are to further the quality and safety of the patient care community. If you haven't done that before, then take some time to learn what that means. And that means learning about leadership itself, how to be a leader. A lot of leaders come into it not really comfortable in their own skin about what it means now that they're going to lead their peers. And so if you learn some of the different leadership types out there, then you can choose for yourself the type of leader you're going to be. Something I often saw was that when leaders came in and they didn't actually learn about the different leadership skins they can put on, they would often default to either being an autocratic leader of I say you do, or they default the other direction to be a can't we all just get along type of leader. And I got to find consensus in every single thing type of leader, which is a nice idea of wanting to bring your peers along with you when you make decisions. But sometimes you're going to have to be the decision maker. And you need to be comfortable with you're not always going to have consensus. You're not always going to make everyone happy. And so when you learn how to balance this democratic leadership that you're doing through the medical staff or in your medical group with achieving the missions of your organization, then you're going to come in and be able to start off on day one rather than spinning your wheels for the first few months trying to figure out how you're going to lead. And I think it's pretty common, and I'm not faulting because look, you practice medicine for years and years, you don't necessarily get education on what it means to lead. Same as with lawyers, same with a lot of professionals. You're not necessarily getting educated on how to lead. And then someone says, hey, you're great at what you do. Let's put you in a leadership position. And you go into it and you think, great, I'm great at what I do. Now I'm leading what I do. But it's a totally different set of skills. And it's a learnable set of skills, but you have a little bit of time to learn that set. Otherwise, you're going to be very frustrated. And the people you're leading might get a little frustrated too.
I will argue, though, that it's not necessarily much about education about leadership, because I know some colleagues will get MBAs and get other advanced degrees and executive degrees. It's not necessarily in the degree. So I think to me, it's the coaching. Coaching really is something that's reserved for anyone who's in the pathway towards executive leadership, primarily because it's the only real way to get that guide on the side training to develop you as you go through different types of administrative challenges. Because leading an administrative team is definitely different from leading a clinical team. In clinical team, we often have roles and responsibilities that are clearly delineated by our professions. And so we stay to some degree in dyads that complement each other. And so whether you have a nurse, respiratory therapist, advanced practice provider, physician, we all have roles, responsibilities that can help each other, but not totally go into somebody else's lane. And so
Mhm.
similarly on an administrative team, like for running an entire hospital, there are also different types of people that you never encountered when you were a clinical lead that you now do need to work with that are very potentially even very different in terms of work style, in terms of the profession with IT and the data and the facilities and like the rules and regulations, lawyers. There's all kinds of people that you work with once you
For
get
sure.
into managing an entire healthcare system that we didn't have the luxury of meeting when we were frontline, even just division chiefs, for example.
For sure. And yeah, absolutely. Education, I don't mean go out and get your MBA before you serve a 2-year term as a chief of staff. I mean, that doesn't make sense. What I do mean is listen to podcasts like yours, read some books, talk to people who've been in leadership, ask them what was it that worked, what didn't work, and get that coach. Have a coach who can help you understand what your role is and how to interact with all those communities that you just talked about. Because it's certainly for a hospital to operate, for a medical group to operate, for any of these complex organizations with such important missions, you are taking care of people in their most vulnerable states. In order for that to be moved forward and to be able to do so in a healthy, safe way, you need to be able to interact in a collaborative way that doesn't step on people's toes, that respects their roles just as you expect them to respect yours. So having a little bit of education about what your role is, educating yourself, I should say, about what your role is, because it's really on you. If you're going to take a leadership position, you need to take the time to educate yourself on what your job is as a leader, and then how you're going to work with other people and build those relationships. And that's another recommendation is like, do some work on how your skills of relationship building, because you need to make sure you can interact as a leader in a way that is going to be productive with those around you. And you don't have to be warm and fuzzy. That's not part of the job description as being chief of staff or medical director. But you need to know how to respect people, and you need to have a sense of how to interact with people, whether they are your peers, whether they are administrators of the institution, whether they are care staff, to interact with them in a respectful way that's really designed to help bring people together to move your mission forward, because that's what leadership is.
Yes, yeah, absolutely. The relationships are really important and being able to spend the time to nurture all of them. I feel like sometimes
Yeah,
in this very hybrid world that we're living in, it becomes much more challenging for all of us to really get to know people, especially when we're spread across very large campuses now.
for sure. And it's not like you have a bunch of free time. Over those 25 years, there were pressures 25 years ago, but those pressures I think have just increased as time has gone on. And so if you have not just your work time pressure, but your family time pressure, and you also need to take care of yourself, when you go into a leadership position, you need to make sure that you're prepared to spend that extra time necessary to make sure you have those relationships with people. And again, it's not about getting a degree in psychology before you become chief of staff. It's just about making sure that you have talked with someone like a coach or have listened to podcasts about building relationships and really set yourself up for that success as you're stepping in day one into that position.
Yeah. So I'm wondering, credentialing and privileging and peer review, they can feel a little bit opaque or not quite clear to most frontline clinicians, especially some of our younger leaders in development. I'm curious, what are the most common misunderstandings about the credentialing, privileging, peer review process, and how can frontline leaders in development become more proactive participants in the medical staff and the system?
Yeah. I think the most common misconception that leaders have is that it's really just a rubber stamp process. Someone fills out an application, they send it in, we stamp it, and they start working. And that's not what the intention is at all. When you credentialing and privileging and peer review are the reasons why medical staffs exist. They came into being for the purpose of overseeing who is going to practice at the hospital. And through credentialing and privileging and peer review, with the exception of actually providing clinical care and how you treat your patients, credentialing, privileging, and peer review are the most effective and important ways that physicians have to protect the health and safety of patients in the hospital community. It's a big deal. It's a big responsibility. And so when you are on a credentials committee or when you're part of the executive committee and making recommendations for appointments and reappointments, it's a responsibility that you need to understand and take seriously. So again, it goes back to that education piece. When you serve on a credentials committee, hopefully your committee will already provide you with education, but if they don't, ask for it. Ask for an understanding of what your actual job is on this committee. What are you doing? Why are you doing it? Why are these questions being asked on your credentialing form? What is it you're looking for in the applications when you see an application come to your desk? I've talked about this for decades. I used to lecture on it through the Institute of Medical Leadership, their Chief of Staff boot camp. I spoke with them for years about credentialing and privileging and how the process works and why it's important. And one of the key things you're looking for when you are evaluating these applications are the red flags. First and foremost, most applications, 99% of your applications, they're going to be nice and clean and all the boxes are going to be ticked the way you want them ticked. And the supplemental information is going to be so bland. You just won't, it's nothing there. And they'll go through and that's fabulous. But every once in a while, for 10% of your applications, you're going to have a red flag. You're going to have something that tells you that there's an issue, there's a concern here. And when you have that red flag, it needs to be taken seriously. It needs to be evaluated with care and with depth to make sure that when you recommend someone for your medical staff, you're not recommending someone who's potentially a danger to your patient community.
I'm curious, what is a red flag? Because I actually don't think I know.
So red flags, there are many flavors of red flags. So the most common red flag is an incomplete application. If someone has handed you an application and it's halfway filled out or they didn't check off certain things they needed to check off, that should stop at the door of your medical staff services department. They should be like, nope, we're not moving this along because we need to have complete information and should be shipped back to the applicant so they can finish filling it out. Most of the time, it's going to come back completely filled out, perhaps maybe even with an apology. Oops, I should have been a little more careful. Here's my complete application. And you're not going to have a problem with it. So it's an easily cleared flag. But it's a flag because you really want to make sure that you never allow an incomplete application to go moving through the chain and potentially get to a recommendation to a point, because you need all that information. Every question should be there for a reason. You should expect that all of that is there. That's an easy red flag. So there are harder red flags. Another red flag is if there's been corrective action against the physician at another hospital, at another institution. So if they've been practicing at a hospital and that hospital terminates them. We're not talking about they move away and they resign. We're talking about they've terminated them. And perhaps they've been reported to what's called the National Practitioner Data Bank, which is this national, many of your listeners may know this. It's a national repository of information regarding physicians that every hospital has to query whenever they're processing an application. So if you see that's happened, that should trigger something, that should trigger a process in your credentialing process to evaluate that more clearly, to evaluate that more in depth. So you should be looking deeper as to why they were terminated. And that's generally asking the applicant, tell us more, what happened here? And also asking the hospital. Because although I loved working with physicians, I was a lawyer and lawyers are inherently suspicious. So we look at, not all lawyers, I shouldn't paint it so broadly, but that's what the job requires. So we look at the answers from the physician and we're like, great, we've got answers from the physician, but we really want to know what the hospital has to say, because there's going to be perhaps a viewpoint the physician has that isn't the same as the hospital. So we want to get in-depth information about what happened. And that can be very challenging to get because hospitals generally aren't really keen to share the peer review information. It's very confidential and you don't necessarily want it out there in the ether. And the physicians themselves, it may not be something that they're very pleased to have to share. So it can be a challenging red flag to address, but just because it's challenging doesn't mean that you gloss over it. You still have an obligation to your patients, to the safety and well-being of your community to evaluate that type of red flag. Another red flag, if they had an action against them by their medical board, whether it's a medical board in your state, or I say medical board, but we could be talking about podiatrists, dentists, NPs, PAs, whoever it is that you're credentialing. If they've had an action by their licensing board, then you want to find out what led to that. Licensing boards, in my experience, they rarely take action. They're usually behind the hospitals in taking action. So if they've actually come to the point where they've taken action, because they also have a high standard of proof to show that action was required, if they've gotten to that point, then you know something is there, and you just, again, have that obligation to check it out. So those are some of the red flags that are there. Some other red flags. If this is someone who's been sued repeatedly for sexual harassment, you want to know that. You want to look into that. Your hospital community includes your staff. Is this going to be a safe place if this physician comes and works at your hospital? So there's lots of things you want to look into. A red flag itself doesn't mean a rejection. It is not a rejection. It's just the beginning of an inquiry. And once you get to the end of your inquiry, that's when you're going to be making your recommendations to appoint or not appoint. I've had plenty of clients where there was a red flag on an application, and it was at the end of the inquiry, the medical staff determined we still feel that with everything we learned, we are comfortable that this person is safe to practice here. Maybe they've gotten additional education, or maybe this happened so long ago that we think in the balance of things, we can still have this person practice here safely. Maybe we're going to recommend appointment, but with some chaperones to begin with, just to see how things are going on. There are options available to the credentials committee and to the MEC as they're going forward. And another thing, by the way, that the MEC and the medical staff should know is that they make recommendations for appointment. And their recommendation is incredibly important because they are the peers. But ultimately, it's the governing body of the hospital that makes the final appointment decision. And that's just law. That's just something that's required by the federal government if you're a Medicare certified hospital, by the Joint Commission if you're a Joint Commission accredited hospital. Most states will have laws like that as well that says the governing body is the ultimate appointment authority. So the governing body is really relying on their medical staff to make those thorough investigative evaluations of the applications, because the governing body aren't necessarily peers. And they want to know that they can trust that the medical staff has done that in-depth review before they make that appointment decision.
Fascinating. And so what you're saying is not just the peer group of in the same specialty that's making the decision. There's a much wider audience that reviews the files, is discussed, everything becomes transparent, and then the decision is still up to the entire team.
Yeah, so that's how it should be. And different hospitals are going to have different processes. A large academic center, for example, is going to have very robust processes that tie into their academic mission and their academic goals. Small rural hospital may just have one committee that looks at the applications as a whole. There's not a huge amount of process involved. Just because it's not a large organization, they don't have a lot of different committee. But on the whole, what you'll see in these processes is that an application will come to the medical staff office. The medical staff professionals within that office will do what's called primary source verifications and look at, did they actually graduate from medical school that they said they graduated from? Did they actually have their license? When does their license expire? If we require board certification, are they board certified? They'll look at those things and confirm that everything there is accurate. And if they see the red flags, they'll bring that to the attention of the medical staff leadership. Once they've done that, it will often go to a department chair, maybe to the whole department. Often the department chair themselves will look at it, and those leaders will look at the application and make recommendations. And then it will go to the credentials committee, which is made up of a multidisciplinary group of physicians on staff. And that multidisciplinary group will take a look as well. They'll evaluate whether they feel like, again, if there's red flags, have we addressed them? Do we need to do more to address them? And then that recommendation gets moved up to the medical staff's executive committee. And the executive committee is, again, giving it that fresh look through that multidisciplinary perspective to make sure that I's were dotted, T's were crossed, and if there's any questions left over about those red flags that might be out there, that those are fully addressed before they make the medical staff's final recommendation to the governing body.
Such a process.
It is such a process. Yeah.
Yes. And it's also interesting to hear that, to me, some of the red flags you described are pretty significant. And yet, at the same time, as we both know, that litigation suits for malpractice have variety of flavors and go on for years. And so some people often feel trapped in their jobs because of that ongoing process. And so what I'm hearing you say is that actually these are all just due diligence on all parties. And really, it doesn't preclude you from actually going to a new job. You can have a malpractice suit still ongoing, and it's okay to look for a new job.
Yeah, so malpractice, I'm glad you mentioned that because it wasn't one of the ones I highlighted, but that an open malpractice case or malpractice judgments against the physician or settlements for large amounts, those are red flags too, and they need to be evaluated. Sometimes what you'll see is that as part of that evaluation, wow, you had one large judgment, well, usually it's like a 7-year period, 5 years ago, but everything else seems fine. Your referrals, your recommendations were fine, your peer recommendations were fine, so we're okay with that. Open cases, I have to admit, are a little harder because when they're open, we don't have answers. That inquiry remains open too. So it really depends on the comfort level of the organization. It depends some on the track record of that physician in the past. If they've gone 20 years without significant malpractice actions, and we all know physicians get sued for a number of reasons that sometimes are not legit reasons, and they may settle for reasons that have nothing to do with actual liability. But if they've gone through a period of time where there's not a lot of malpractice or no malpractice actions or no, I should just say actions, it actually has to be like settlements or judgments against the physician. And they have this open case now, a medical staff might say, we feel we're comfortable enough. Yes, they have this open case, but everything else bodes in favor of recommending the physician so they can make that judgment. But all these committees are made up of people. And individuals are going to have different takes on this. So at another hospital, they might have a different take on it. I would say, and obviously I'm not advising anyone, I should do my disclaimer, my lawyer disclaimer. I technically am still a lawyer, even though I'm not practicing law anymore. But I'm not giving any legal advice. Anything I'm talking about is just legal information. But what I would say is that individuals need to decide for themselves whether they're going to explore going into a new job. And maybe before leaving their old one, have some conversations with where they want to go about what the impact of this open case would have on their application process and try to get that information just to make sure they're not caught unawares when they're going through the process.
Yeah, it is such a process, litigation and all of that. And for everyone listening to our podcast, check out our previous podcast with Dr. Gita Pensa on litigation stress and just the realities of you are much more than just the one case. And even with this podcast with you, Sarah, realizing that the credentialing and privileging process, it's just a process of due diligence, checking, being transparent, and being honest about all of the things that are related to your professional career. And it's just a conversation to make sure that everyone is on the up and up. Even whenever there are things that are what seems to many physicians, especially when they're younger, seems as scary as actually being named in a suit because it is so common. Yeah. So I guess that goes into my next sort of black box of wonders is the mental health stigma. So many also are afraid to get mental health care in healthcare because there is a stigma related to the credentialing and licensing practice. There is a myth surrounding, and actually in many forms, there still are those very odd questions asking you about your mental health, and then just a question about your physical health too. Like you have to have someone sign off to say that you can physically practice. For example, the Dr. Lorna Breen Heroes Foundation has been really instrumental in trying to advocate for change to remove from the medical staff applications mental health questions that violate the American Disabilities Act. I'm curious from what the medical staff perspective, what kinds of decisions and education and sort of policy change has been happening over the last couple of years to adopt these types of recommendations from the foundation.
Yeah, it is such an important topic. Let's say pre-pandemic and even, again, 25 years of practicing. When I started practicing, these questions about past treatment and current status and, oh, you had mental health treatment. Okay, we need to dig into that a little more. It seemed, yeah, of course you'd ask that. Your job as a credentialer is to assure the safety of the patient population. That is, your patient community safety comes first. If someone has a healthcare issue, whether it's a physical issue or a mental health issue, then we've got to make sure, we've got to get really comfortable with the idea that they're going to be safe to practice at the hospital. And I don't think that we gave it much thought. I'm sure many people did, but I, as my clients had these on the questionnaires, I didn't give it much thought. And it was only as we saw the effects of for example, the pandemic on burnout and pain that it caused people, and hearing Dr. Breen's story, which is just incredibly tragic, that it suddenly hit me in the face that, oh my gosh, these questions, there's problems with these questions. These questions are actually stopping people from getting the care they need because they are afraid of these questions. And that certainly wasn't the intent at all. The intent wasn't to discourage people from getting treatment. It was, again, we're protecting patients. And we want to make sure that we're comfortable that someone is safe. And it was just done with such a heavy-handed, take a hammer to it way that it was having this opposite effect of making physicians sicker, iller, because they couldn't get the treatment that they needed. They felt they couldn't get the treatment they needed because the stigma would stop them from getting the jobs, from being able to practice. So I greatly applaud. And I'm grateful for the education that the Lorna Breen Heroes Foundation is providing to the credentialing community, the medical staff community, the lawyer community, as to the necessity to rethink which questions, how to ask questions. So we're still balancing because patient care and patient protection are important, but do we need those in-depth questions to get there? And the answer to that is no. And so how do we get there? You can get there with just questions that just simply ask, is there anything that prevents you from practicing safely? The foundation has questions that they propose that hospitals and medical staffs adopt to learn the extent of information they need to achieve their responsibility for patient protection, but that don't cross the line. And although, honestly, as a lawyer, I'd wordsmith some of those questions just because there's things there that I might ask a little differently. But overall, I think those questions are things that medical staff should be really considering and changing. And processes, too, because you can change. I described the medical staff credentialing process, right? It goes from here to here to here. Some medical staffs do is for questions regarding health, those questions are cordoned off. You ask them, they get answered, but they're not considered by any committee at all until you make the recommendation. So you get to the point where you get to the recommendation, yes, this physician has all the qualifications necessary for membership on our medical staff and for these particular privileges. Okay, now we look to see whether there are self-identified some health issues where maybe they need some reasonable accommodation. And we figure out how we apply those reasonable accommodations, if we can provide reasonable accommodations within those privileges that we've granted. So it's not even a consideration for appointment and privilege granting. It's just something that comes up at the end of the process as to whether accommodations are necessary.
Yeah, and it's one of those things that's not widely known to anyone, because the reality is it is very odd to think that all humans will need some kind of accommodation in some way. And the perception of what accommodation means in terms of schedule flexibility versus adaptive hearing or assistive devices versus a normal health benefit for all humans to get mental health care. So it's really interesting, the conceptual employment process of how that sort of all plays out. Because at the end of the day, physicians are human. And so human things will happen to you.
And, some of those adapt, it might just be you need different lighting If you're a surgeon, you need lighting a different way or whatever. There's things that can be done. And sometimes the hospital cannot provide those accommodations, or those accommodations in the end are deemed not to be reasonable. The requested accommodations are deemed not to be reasonable. And that's a discussion that, again, goes back and forth. That's where you want to be transparent and you want to have discussions. Can we make it happen? And if we can't, do we have a good reason? Is it, again, a patient care reason why we can't accommodate? But it should never be, well, we can't accommodate the fact that you sought treatment for your burnout or whatever mental health stressors you had 3 years ago. Now we can't accommodate you. It should never be that. It's not about that. And I think that the way the questions had been asked in the past, that was what was seeping in. This idea that your past mental health treatment made you unreliable to practice.
Yeah, there were definitely a lot of antiquated, I think, ways of thinking that perpetuated cultures and perceptions in general. So hopefully times will change.
Yeah, I think they are. I think they are.
Yeah,
It's a
things are
process.
changing.
It's a process. Yeah.
Yeah. And so I think what also surprised me is the degree of state-to-state variability and how much locality and the individual hospital themselves even different from the system. So systems at least have larger jurisdiction over all of the different hospitals that are member groups. Affiliations, branding, who controls what, I think is the most interesting thing about the variability that does exist across all sectors in healthcare in general. What you've told us about is the fact that can be at one place and it might be different right across town in a very similar hospital for a very similar board. I'm curious, if you had one pearl for our young leaders in development and the whole credentialing and processing, you have your career ahead of you, what's one piece of advice you'd give to the young leaders in development?
The young leaders, it would go back to my very first piece of advice, which is if you're a young leader in development, really try to figure out what kind of leader you're going to be, how you want to lead. Start incorporating that into other leadership activities. Leadership is a skill, and like most skills, it can be learned. And how do we learn? We learn by knowledge acquisition and experience acquisition, which is just study and practice. So go out there, get educated about leadership, and look for opportunities to exercise those leadership skills so that when you get into those bigger leadership opportunities, you can just really start from day one, moving your organization's mission forward. Because as a healthcare leader, your organization's mission is all about patients and patient care and patient safety. And so that mission is something that you want to move forward. You want to keep it going strong. And so that would be my nugget of wisdom for those new leaders out there.
Sounds good. And so where can people get in touch with you or find out more information about you and work with you?
Great. I'm on LinkedIn, but also I have a website at sarahbenatorcoaching.com. I'd love to hear from you. I've loved working with physicians. Like I said, for 25 years, they're some of my favorite people. I have such great respect for what physicians do because they are balancing and managing a lot in this world, both as professionals and in their personal lives. And I have a lot of awe. Good job, you.
Awesome. Thank you so much for helping demystify some of that credentialing and medical staff process and all of the things that we didn't really ever want to talk about or know where to get the answers to. So thanks so much for coming on our podcast and have a wonderful day.
My pleasure. Thank you for having me. You as well.
Thanks so much for listening. If you found value in today's episode, please subscribe and share with a colleague who would benefit. Together, we can transform healthcare one person at a time. Find us anywhere you find your podcasts. Ready to take your healthcare leadership journey to the next level? Book a discovery call free at transforminghealthcarecoaching.com to explore our personalized coaching packages designed specifically for healthcare professionals like you.